Okay, this is the third part of our elimination lecture, and we're going to begin talking about colostomies. Now, let me point out a couple differences here. Uh, Ileostomy is where they bring the small intestine to the surface, and a colostomy is where they bring the large intestine to the surface. And if you look at the picture, let's look at the upper picture over here on the right. You can see that little red stoma there. That is the inside of the intestine, and they bring it to the surface. Often the person can't eat, or maybe they've had cancer and they've had surgery, and it's a way that the person will be able to expel their stool, uh, and it may be temporary or permanent. I want to highlight just a couple things to you guys. Look at that stoma color. It should be nice and beefy red. If it's black or dusky or bluish in color, that means it's not getting blood supply, and we need to call the surgeon. It should be nice and beefy red. The second thing I want to mention is the effluent. Effluent is what we would call the poop that comes out of that stoma. And effluent, depending on where on the intestine is, can be uh, like pasty or more solid, or if it's on the proximal end, it can be more watery, and so it will change in consistency. And we'll go over that on the next slide. The person is going to wear what we call a pouch or an appliance, and if you look at the lower right corner there, you can see that the person has a pouch. They have the little stoma sitting there. And what we need to do as nurses is give the person really good skin care. We need to protect that skin around that stoma. We don't want the enzymes and the poop and stuff to break down the skin. So skin care is very important, and so we'll talk about that. Odor control is also important. These can smell real badly, and so we need to control the smell and also the gas. And then this person will have body image issues, and we'll talk about that in a couple different slides. And like I mentioned, this can be temporary or permanent. Okay, and I mentioned this that depending on where in the colon they bring the stoma to the surface, the effluent is going to change in consistency. So let's take this picture right down here in the ascending colon, and so most of the large intestine has been removed, and so you don't have the intestine to reabsorb the fluids, and so a colostomy in the ascending colon is going to be very liquidy in the effluent. And let's go to the complete opposite one. So let's take this picture right here over at the sigmoid colon. Now they still have a large portion of the large intestine, and so they will absorb a lot of the fluid before it gets to the end here. And so now that effluent is going to be more formed and look more normal. And then let's look at this picture right here. Let's say it's the descending or the transverse colon. These are going to be more semi-liquid. Okay. And things that we can teach our patients about odor control, have them stay away from onions and garlic and beans and cabbage and stuff like that. That'll make it so that the effluent isn't so smelly. Things that they can do would be to eat cranberry juice, drink buttermilk, eat parsley, use our charcoal filters or pouch deodorizers to help control the smell. And to control the gas, have them again stay away from beans, onions, cabbage, stuff like that. And what they can do to help with the gas would be to eat crackers, toast, yogurt, or use a gas filter. And the next slide here, this one we usually talk about body image issues. And people that have a colostomy or an ileostomy will have body image issues. And as a nurse, it's real important that we watch the faces that we make. We don't want to make funny faces or make the person feel bad. We don't want to say, oh my gosh. We need to be very professional, and we want to help the person with their body image issues. And the picture right up here with the gentleman, I think he's a triathlete. They actually make these little plugs that the person can plug the stoma, put a piece of tape over that, and they can go out in public, and you don't see this bag, with all this effluent hanging there. because this picture here that was photoshopped, a student made that for me. If you go out in public and you have a bag and it has effluent or poop in there, it'll be real embarrassing. And so it's nice that they make the little plugs that people can go out in the public with that. Okay, benign prostatic hypertrophy. This is a very common disorder in older men, usually older than 50 to 65 years of age. And what happens is the prostate gland enlarges and it blocks the flow of urine from the bladder. And assessment, you're going to find that they have increased frequency. That means they have to pee all the time. There's going to be a reduced force. So instead of a strong force of urine, it's going to be kind of a dribble, dribble, dribble. And that's what it says right there, dribbling next. They'll have an inability to empty the bladder, and so they have to pee more often. They'll have to strain to urinate, so the grandpa may go into the restroom and he stands there for a while before he'll be able to urinate, and he really has to push, and then finally the urine will flow. They may have blood in the urine, and then this is a very common sign and symptom. A lot of the first ones that will give us a key that the gentleman has BPH is nocturia. He'll get up 3, 4, 5, 6 times during the night to go to the restroom because he can't empty his bladder fully. And they may also have dysuria or painful urination. BPH is diagnosed by a rectal exam. It will be enlarged, or by cystoscopy, and they'll see the enlarged prostate gland and the obstructed urethra. A couple treatments that they may try before they go to surgery is to use alpha blockers, and these cause the smooth muscle to relax and make it easier for the gentleman to urinate, or the enzyme inhibitors, and these prevent the conversion of testosterone to dihydrotestosterone, and it helps decrease the size of the prostate gland. Okay, and things that we can help teach the person would be to avoid large quantities of fluids, especially alcohol in the evening. That way they don't have to get up all the time during the night. And if the medications and these treatments don't work, then they'll go to surgery. And the old standby surgery is TURP, transurethral resection of the prostate. And that's where they have a resectoscope over here. And it's kind of like a cautery knife where they stick that into the urethra and they cauterize the lining of the prostate gland there. And it opens up the passage so that they'll be able to urinate better. So that's the old standby. Some of the newer treatments are TULIP, where they use laser, balloon dilation. They can use microwave, high radio frequency, incision, or ultrasound. So these are all newer type of treatments. So let's start with this one here, because I see a bunch of test questions on this slide. You need to tell the patient that they're going to have an indwelling urinary catheter for 1 to 2 days post-op, and it's going to be draining blood-tinged urine. It's going to have blood clots in it. And the person needs to know that they're going to have a 3-way Foley catheter in there. Now, you guys know that the catheters that we put in patients have 2 ports. This one has an extra one. And so there's the balloon port, there's the drainage port that you guys are used to, but it also has a 3rd port, and this is one where we irrigate. And so we're going to hook them up to a huge bag of normal saline. We're going to infuse the saline into the bladder, and it's going to wash the bladder and hopefully wash the blood clots out. And then down in their urine bag here, you're going to see blood-tinged urine and some blood clots in the bag. So make sure that they know that they're going to have that. Make sure that they know that there's blood clots and that's normal. One other thing I want to mention is that this Foley catheter that they put in, this 3-way bag, it's a large one. You guys are used to 16 French, and most of the patients that you've seen so far in the hospital. Well, here they may use 25 to 34 French, so it's a larger size, and this helps put pressure on the walls of the prostate gland to help stop the bleeding. So they're going to have this continuous bladder irrigation, and And as a nurse, you need to monitor the amount of solution that's going in and also the amount of solution that's coming out. The reason we say this is sometimes down here at the balloon, those little lumens that are there, they will be plugged with blood clots. And if there's not as much urine and blood coming out as what we have going in, that means that it's clotted off. And what you'll need to do is to get a large syringe, usually one of those 30 to 50 milliliter syringes, and you're going to instill saline in through the tubing, and hopefully it'll wash that clot off the lumen at the end of the catheter, and it'll allow the urine to flow again. And then sometimes these guys will be incontinent post-operatively, and so you want to teach them Kegel exercises post-operatively to help regain control. And then this is the last slide. It's just a way to remember some of the treatments that and signs and symptoms that you'll see with TURP.